thanks to the London Kidney Network Group for inviting me to help with the prevention side of things. You know, I'm sure we all know this, but, you know, from our epidemiology data, demographics, lifestyle changes, the next 10 to 20 to 30 years are going to see a huge change in the prevalence of CKD, driven primarily by the prevalence of diabetes and its complications. And so we're really at a juncture that there's an urgent health need to try and address these factors. Fortunately, the last sort of 5 years have seen a golden age in new therapies to help prevent the devastating complications of diabetes and proteinuric kidney disease. So we're really delighted to be able to bring together, as part of the LKN, experts across the spectrum, from primary, secondary care, allied health professionals, patients, NHS leaders, really to help find and hear from you, innovative solutions to prevent the devastating complications of CKD. So we're going to have some talks now. We'll have some time for questions at the end, but by all means, if you've got any questions, you can type them in the box and we'll respond to them at the end of these talks. So next slide. We're just delighted to kick things off with Catherine Croucher, who is a consultant in public health and works at NHS England, and she's going to talk to us about diabetic kidney disease and population health in London.
Good afternoon, everyone. Thank you, Kieran, for that introduction. I'm just going to spend a few minutes going through some slides that depict how those risk factors that Rob has just outlined for you, and how the utilisation of renal services varies across London. It's worth saying that for the simplicity of just a few minutes presentation, we're looking at London here. But of course, we acknowledge that the London Kidney Network, of course, looks after people from outside London, especially across Surrey, and rest assured that all the data that you see here is available for that area as well. Thank you. Next slide, please. So again, this report from Kidney Research UK is quite famous now, and we have already had a recap on how your socio-demographic status and your well-being influences your risk of CKD, how fast it progresses, and what services that you have access to. And this is really at the heart of equity analysis. Next slide, please. Here we're just looking at 3 of these demographic factors: age, ethnic group, and deprivation. The chart on the left is showing how much younger in structure the population of London is compared to England as a whole, but also how much more diverse it is in terms of ethnic group. And the map on the right is depicting socioeconomic status. The map is showing some very small areas, but when we're talking about integrated care system areas, on average, it's North Central London and East London that have those higher than average levels, with South West London being lower than average. But it's worth pointing out that across an ICS, the average level is going to mask all manner of pockets of deprivation that, when you're working at locality level, are going to be really important to take into account. Next slide, please. So how many people do we think are living with moderate to severe chronic kidney disease, so stage 3 to 5? We roughly think it's just over 280,000, and we estimate that by using the Health Survey for England, which is a representative sample of people, and in 2016 it focused on kidney disease. They took blood and urine tests from their sample, and that enables us to produce estimates of the numbers in each area, and it takes into account the age and sex structure of those populations. But a couple of caveats. One I've highlighted in here in red: Health Survey for England doesn't record ethnic group, and so it's highly likely that the estimates for London will be an underestimate because of that fact. They also don't go into institutions like care homes. So in terms of trying to judge how many people are living with very severe end of disease, that might also be underestimated in the Health Survey for England, because they don't go into the places where people are highly likely to be living with that level of disease. Next slide, please. So moving from the general population into those cared for by primary care, and again we're comparing those estimates from the previous slide with people who have been diagnosed and recorded on kidney disease registers in primary care, more commonly known as the Quality and Outcomes Framework, and the gap between them. It's commonly accepted a smaller gap is better, and across London we've got a gap of about 30%. And I've just put a red circle there around East London with that fantastically small gap there. I'm not going to go into any conclusions about that. I know that we have speakers later on in the agenda who will be talking about the experience of working with primary care in East London, and perhaps can explore that further. I've also put on there the diabetes care processes as well. As Kieran mentioned, these two conditions are so closely aligned that I thought it's worth just a check on how London fares in terms of their implementation of care processes and treatment for people with diabetes. And you can see there, that across London it's pretty consistent with England, if not slightly better. Next slide, please. So jumping right to the other end of the care pathway, those with end-stage disease and those receiving renal replacement therapy. So all of this data comes from the excellent UK Renal Registry. And actually this analysis and the way it's being presented is brand new, literally last week. So we haven't really had chance to explore it, debate it, get clinical input of it. So this is really the first glance at this, the way it's been analysed. Perhaps the graph on the bottom left is the most simple to explain, and I know Professor Banerjee later on in the programme will be exploring the impact of ethnicity, but it really shows that kind of stark moving away of rates of new renal replacement therapy patients in 2019 between the different ethnic groups. The chart there of late presentation, that gap between referral to renal services and starting on a therapy, generally accepted, but a lower rate is better. And for where we have data across London, you see three of our areas are pretty consistent. Something's happening with South West London. It's not shown here, but the rate for Surrey Heartlands is on a par with the rest of London, despite using the same centre. So there's something about the people who are resident or registered with primary care in South West London, because that's the basis for this analysis. It's not by centre, it's by area of registration. There's something going on there that needs further investigation. And just for reference, we've put up there the 5 ICS areas that do have the lowest rates in the country. And just briefly, the top table there, 11,500 people on renal therapy at the end of 2019. Remember, this is by area of primary care registration, not centre, for those of you who are wondering why it's not nearer 15k, as shown in an earlier slide. This is not by centre. And we've got 2 areas that are lower than you might expect when compared to an England average. That's the ratio in the last column there. And 1 area that's higher than you might expect. And for the first time, we worked with a registry to attempt to adjust these rates for ethnicity. In the annual reports, they're typically only adjusted for the different age and sex structures of populations. But we've had a go with the ethnic group adjustment as well. And again, we've not had chance to consider the interpretation of these rates. It's not necessarily straightforward, but we look forward to doing that as the next step. And next slide, please. here I've taken all the numbers that we've just looked at and tried to place them in a logical place on a very, very simplified care pathway. So how do we get from 8 million people registered with a GP in London through to that nearly 12k on renal replacement therapy, 6.5k on dialysis, and if as current trends continue, that could go up to 8 by 2028. We've already seen the detail of those projections. And it's this middle part where what we're talking about today, that opportunity for early identification and prevention or delay of progression. But we've got some question marks in here on the data of where we need to get to in terms of understanding how people move through non-specialised secondary care, nephrology services, the numbers involved in specialised pre-assessment clinics before going on to renal therapy, and how people move from one treatment modality to another, and in particular with supportive care as well. So that's some blanks that we've got to fill in and further explore as we develop our knowledge of our population data. Next slide, please. And then just as we were getting to grips with the data, all I've shown you is up to 2019. Of course, we're going to have to understand what COVID-19 means for kidney disease and the size of that renal replacement therapy population. Will it increase because of potential lack of opportunity for early identification and prevention in primary care? What about COVID-related acute kidney injury? What about that pause in transplant surgery? And what did that mean for people with kidney disease? Or might it decrease, very sadly, because of the very high mortality rate amongst the renal therapy population? So we need to understand all of that, what it means during the pandemic now, and what it means as we move from a pandemic to an endemic situation and we learn to live with COVID-19. So on that rather challenging note, I will leave it there.